I so, but the funny part is that although we haven't known him for a very, very long time, when I say very long time, we're talking about decades, I can't quite remember when it was that we met. It seems to me that he's always been in our lives, and I feel,
Ingrid came into
Nice.
the national conference here
yeah, but I don't remember exactly the year. But
about 5 years ago.
was it been Craig? How long has it
I
been?
think it's been longer than that. I think it was Julie's birthday party I met you at.
Oh my God, that's closer to 10.
Yeah, I think it was almost seven or 8 years ago. Yeah,
That long
Where
ago.
was that at North Pond?
it was.
Yes.
Yeah, I was there.
Yeah.
And it seems
Oh my
like
God.
you know, as I say, that he's been in our lives for a very, very
Forever.
long time.
Oh
He's,
my
you know,
God.
he's an ethicist, and the funny part about ethics is that everybody thinks they know what it is, and they know what ethics, you know, what comprises ethics, and it is not common sense actually. Well, there's an element of that in it. It really is a very, very distinct academic, uh, you know, area, and medical ethics. And Craig and I have talked about this. Medical ethicists are often called in, and at least in the clinical grounds, to referee between clinicians or disagreements on how patients should be managed in certain ways. Often the nursing staff initiates these ethical consults because they don't agree what the doctors are doing, and they're looking for someone to side with them so they can beat up on the physicians. And that is not what medical ethicists do. Um, I know we're talking about Craig. Michael just wrote to me, "Get on point." that was
We're
was
introducing Craig. We're not talking.
no. We're talking about
Ethics.
no, but we're talking a little bit about
Michael, it's context.
you know. So, but anyway, Craig, I have to say that if I were in practice, and I had a choice between who I would call to help define for us the ethical issues and also to work with families because they also do that,
Yes.
he would be my number one choice. Because besides being as smart as they come, and you could tell a little bit from his opening remarks or a conversation how really bright he is, he's a wonderful person. And I don't think I have to say anything more.
I just want to add something, because you don't think of the work Kubler-Ross on death and dying that Craig has had experience with. So I think he's not only is he a brilliant academician, but he's a very compassionate person, which makes him a wonderful ethicist. With
Anyway,
that,
well, that's it. We're going to shut up and let him talk.
Craig.
Yeah, I'm on the verge of crying here. Thank you. So I have some slides I prepared, some educational component. If we get to it, great. If we don't, that's okay too. Please feel free to ask questions. If you know how to use the chat function, that's a great place to put your questions so we don't lose them. Or just jot them down if you don't, but if you can also just break in at any time, that's fine. So let me start with this. And okay, does everybody see the title page? Okay, get a wave of hands. Have you had your shot?
Yes.
Ethics and discernment. Excellent, thank you. Okay, so it's just kind of a neat little Microsoft thing here. All right, so as of today, there have been almost 103 million cases of COVID in the world. To give you some, well, I'll give you perspective in a second. That is 1.3% of the world population. There have been 2.2 million deaths. Here in the United States, as of this morning, we have 26.1 million cases, and that is a little under 8% of the entire US population. When you realize that we are 4% of the population of the world, we are 25% of all cases in the world. That shows you how poorly we have responded to this as a country. We probably, as of now, but this morning it was about 440,000 deaths. To give you an idea of how exponential increase works, 90,000 of those deaths were in January. So It's getting worse. So we also have 20% of all deaths around the world. And the death rate for this is 1.7%. So if you have this disease, if you come down with the infection, you have a 1.7% chance of it killing you, which may seem pretty low, but that is double the rate of, well, actually it's triple the rate of flu. So it is significant sort of numbers. And to give you some perspective, January 21st was the report of the very first, well, actually January 20th was the very first, 2020, the very first case of COVID in the United States. So in 1 year, we've had 26 million cases. Right, sobering, I know. Another perspective is, now this is very preliminary data. It usually takes a year and a half after a year ends before we know the leading causes of death for that year. But it looks like COVID-19 was the third leading cause of death in the United States in 2020, behind heart disease and cancer. That is significant. And you can see it's a substantial difference between those three and the next ones on the list. So this is something that has hit us and hit us very hard. What you're probably all interested in at the moment are the vaccines, because obviously that's the rollout that is happening. So there are 4 different technologies being used for the vaccines. And so when we talk about, what's new in this pandemic versus previous pandemics in human history, vaccines are one of the new things. So of the 4 types, the first is a whole inactivated virus. So this is basically a deadened form of the virus. This is one of the oldest technologies that we have for viruses, right? This is what the polio vaccine was based on. This is what most of our childhood vaccines are based on. And basically you take the virus, you kill it, and then you introduce it to the body so that the body's immune system can recognize this cell, this invading cell, and it can produce the many different immune cells that we have to respond. So if you think about, these are the soldiers that our body produces in order to go after this invader. And it remembers it. So our bodies, even after the invader is gone, our bodies remember it. They maintain some of those immune cells, stay around. We have the blueprint so that next time it shows up, the body can recognize it faster and can get new cells pumped out even faster. So that's the whole idea between vaccine, is we're priming the body to be prepared to march against these invaders. So this is one of the oldest technologies we have for for vaccinations. And you can see Sinopharm and Sinovac. These are 2 Chinese companies. That's what the Sino says. So this is the Chinese version. What they have done. The next technology that we have seen is an mRNA or an RNA vaccine. So this is a very modern, this is 21st century technology. An activated virus is like an 18th century technology. So 21st century technology. We can deal with this. It's based on 20 years of biological research, and we can really get this out very quickly. And so that's the Pfizer and the Moderna versions. And what it is that if you can see this, it's my little tiny. So we have a double-stranded helix of DNA, and if you untwist it, you get a single. You have 2 strands, and you take one single strand. The gene that we're using codes for the spike. So if you see this picture, all these red little spikes, we have the gene that can code for this, and we only have 1 strand of it. So like DNA is a double helix. So we're just using 1. And this is inserted into a piece of fat. So it's a little fatty tissue, because your cell walls are all made of lipids, made of fats. And we inject this into the body, and it gets absorbed into cells. And then the cells have this reaction of the immune system getting primed. So this is the Pfizer and Moderna. These are the 2 that have been approved by the FDA. Partially approved by the FDA. Okay, a third is a modified virus, or what's called a viral vector. So in this, you take the DNA, some DNA from the virus, again, for the spike, this little red tower here, and you insert it inside of another virus. But the virus you inserted it into is rendered harmless. So the Johnson & Johnson, which just recently came out with its stage 3 clinical trial results, it's inserting the DNA of COVID into an adenovirus, which is just a common cold. And because it's the common cold virus, a virus essentially is a coat with some genetic material on the inside. And if you take out, and the coat is primed to insert into cells to invade, it injects its genetic material, it takes over the cell, replicates, kills the cell, and then gets sent out into the body to do this over and over and over again. So if you take out the genetic code that's inside this viral coat, if you take the code off of one person and you put it on another, and you know how to control this virus, you can actually get the DNA of a different virus into a cell and have it start producing and prime the system. So that's what the Johnson & Johnson does. There's some advantage to theirs. And then the last is called a protein subunit, where you take not the DNA, but you take a piece of the virus. So in this case, we're snipping off pieces of the spike, just like you would cut fat off of a piece of chicken or something. So you're cutting off pieces of this protein and you're injecting this into the body to try and create the same system, to prime the immune system again. And this is the vaccine that has just been announced on Saturday, called Novavax. And so we're just giving people pieces of the protein to prime their immune system, right? So these are the 4 technologies that are being used in order to prime our immune systems. What's kind of nice is that these don't stay in the body. So after they've primed the immune system, we get rid of them. We shed them out of our body. So there's not sticking around. It's not like polio where 40 years later, it's going to start invading us, or even something like chicken pox, which stays in the nerves. And then if you have you get older or your immune system decreases for some reason, it just kind of sneaks out and starts infecting you again. So these aren't going to do anything like that. Now, if we compare these vaccines, we can sort of see the differences. So we've had reports on the effectiveness. Moderna and Pfizer are 95%, which is amazing. There really are no vaccines that have been that effective in our history. We thought we'd be thrilled if we got ones that were 50 or 70% effective. So the 95% is truly amazing. They each are 2 doses. In fact, most of these are 2 doses. The challenge with these 2 vaccines is they have to be kept at very cold temperatures. So the Pfizer needs to be kept at -70 Celsius, Moderna at -20. So this is colder than your standard refrigerator. The Pfizer has to be an ultra low refrigerator. There aren't too many of these anywhere here in Chicago. We've got 4 large freezers that can handle this. And these are the 2 that have received emergency approval from the FDA. Emergency approval means that it has been shown safe in a clinical phase 3 trial, but it hasn't gone through the entire process, which takes much longer. So it would be, normally it's several years till we get approval of vaccine. So it also means the FDA is still tracking these. So you can go to the FDA website and they're collecting information from people who are giving the vaccine. They're collecting side effects. So if you get the vaccine and you have a side effect, you can report that, your doctor can report that. And so we're still collecting information. And they've also been approved by the UK's version of the FDA. Now, Johnson & Johnson that just announced, they said they had a 66% effectiveness, which normally would have been great. But our concern is it's not 95%. The advantage of this is it's cheaper and easier to make, and it's a single dose. And it also seems to be that it works differently against different strains. And I'll talk about the variants in a little bit. So in the United States sample, 85% of people, it was 85% effective. It's 100% effective at preventing hospitalization and death. So that's huge. But in South Africa, ZA, it was only 57% effective. And that's because in South Africa, there's a predominance of a new variant. And our vaccines aren't as effective against it. So not only is it 1 dose, but it can be kept in a regular refrigerator and freezer. So you don't need anything special here. They are applying for their FDA approval this week. So this might be approved by the end of February. And if that happens, we should start seeing a quickening in the number of people getting vaccinated. So Novavax, this is new. They've just reported, actually Saturday, their numbers. And they're at 89.3% effectiveness, which is fantastic again. It is a 2-dose vaccine. It's a very cold fridge, but your freezer you have in your house would be fine for this. It's capable of doing that. And they have not announced when they're going to go up for FDA approval yet. Sputnik is the Russian version. They're claiming it's 92%. They also haven't shared any data, so we don't know what it's based on. It cannot go to the FDA because what happens is in the UK and in Russia, the company does their trial. The company comes to conclusions after analyzing their data, and then they say, look, it's 95% effective. The UK says, great, stamp of approval. In the FDA in the United States, they say, that's lovely, give us the raw data. And they analyze and calculate it out themselves. So it's an independent second verification, which is why it takes longer. It does in the UK. So Sputnik has not introduced, we haven't seen the data. We don't know anything about it very much other than the claims of the Russian government. And then the other one that's sort of moved along is the Oxford AstraZeneca. They have had a setback because there were some inconsistencies in their trials. But what they've reported so far is about a 70% effectiveness rate, which is still good historically. It's a 2-dose, but regular storage, so that makes it easy. And they have not been approved in the United States. They haven't even applied for that, but they have been approved in the UK. So this is one of the versions you can get in the UK if any of us could actually ever go there. So those are the different kinds of vaccines. Now, we've been working on distribution. This might be the thing that interests you all the most. As of this morning, we've given out about 28 million doses in the United States, which is about 57% of all the doses released by the federal government, right? So 49 million doses have been released by the federal government. You might say, why are we keeping half of these from being given? And the reason is that the 2 that are approved for use here, Moderna and Pfizer, require 2 shots. So we're keeping your second shot in the freezer when you get your first one, so it's still there. In the UK, they have decided not to keep the second shot. And so they're giving 100% of what they get in. What it means is that when you need your second shot, there might be some there, there might not be some there. And the FDA said that they are going with the schedule that was approved in the clinical trial. They're not going to change that. The UK said, we'll change it. So maybe it's instead of 3 or 4 weeks, maybe it's 9 or 12 weeks. The FDA is not letting that happen. A little under 7% of the US population has received the first dose of the vaccine, and 1.4% of the US population has received their 2 doses. 1.4%. So when you hear people talk about herd immunity, according to Dr. Fauci, whose wife is a bioethicist, by the way, we have to hit 85%. We are at 1.4. You can see in this chart here, the darker the green, the more percent of the state's population have received the vaccine. You can see it's pretty low in most places, Oregon, Illinois. The places that have had a lot of, had a higher proportion, we're still talking about 12%, so it's not huge numbers, are small states, are places with a low population. So it's pretty easy to get the proportion of the population numbers very easily. The plan for how we allocate in the United States came about through a combination of the CDC and the National Academy of Science, Engineering, and Medicine. And they put out this program in November, I want to say, with a period for public comment, and it didn't change very much after the public comment. I attended a webinar they gave on this. And what they said was they looked at certain ethical principles on which to create the framework for how we would distribute the vaccine in our society. They wanted to maximize the benefits. They wanted to give equal regard, so treat everybody equally. They wanted to help mitigate health inequities. They wanted it to be fair. They wanted it to be based on scientific evidence, and they wanted transparency. So you can see why the Trump administration didn't do very much with this, because not things that they believed in. But life is different now. And when you think about, so who do we decide who gets the front of the line? The hope is that by the end of 2021, anybody who wants a vaccine will be able to have a vaccine. But who gets to be on the line first? Who gets the first doses? And so when these committees sit down and make these decisions, and I know this because I helped do this for the state of Illinois, I helped for the state of Texas, I've helped for the borough of Brooklyn. there's different things you have to balance. So one thing we could consider is, do we want to save the most lives possible? If we want to save the most lives possible, then we give most of our doses probably to seniors. New Jersey has a very controversial decision. They've decided to put smokers near the front of their line because lung disease is one of the things that makes you more likely to die and need hospitalization. So they have them at the front of the line. So we could decide we're going to save the most number of lives, the most people. We could also think about saving the most life years. So instead of people, we want to maximize the number of years that people on the planet now would be able to live by getting this vaccine. So what's the difference? So if we're going for most lives saved, let's say we have 4 people who can get the vaccine and we have a few doses. 3 of those people are over age 90. 1 of those people is age 20. If we go for most lives saved, we would give it to the 3 people over 90 because they have the highest risk of dying, and we would be saving 3 lives versus giving our vaccine to the 20-year-old, and we would only save 1 life. But if we want to save the most life years, we would give it to the 20-year-old because when you figure at 90, you might have 5 years of life expectancy, but at 20, you have 50 to 70 years of life expectancy. And so by giving it to that one younger person, you're giving it to most lives, you're saving the most life years. So this approach obviously is ageist because it goes against people who are older. You would just not give it to them, right? So all the frameworks that we can choose have implications for basically discriminating against groups of people. Some have suggested we should look at quality of life. Who would have the best quality of life being saved here? But that is a judgment. What is a good quality of life? And this actually can bias against people living with disabilities. And so this is one that we're not doing. Okay, so that's one set of issues that we balance and we think about. The other is, what is our goal? So are we trying to reduce mortality? Are we trying to reduce the number of deaths? Are we trying to reduce morbidity? Like people getting infection, hospitalizations, and really a lot of our vaccine process has been about making sure that we don't overwhelm the hospitals. This is why we ask people to wear masks and to stay at home. We want to not overwhelm the hospitals. We also want to reduce the sort of long-term health implications, what are called the long haulers, because we don't know what this will be. And, my dad is 78 and he had polio when he was 6. He has had to deal with things his entire life. What will it be like in 70 years for the people getting it now? Those sorts of questions. We can reduce the number of infections. We could reduce inequities. Do we make sure that we give it to people who haven't had a historic experience? Maybe they haven't been able to have health insurance, or they've lived in areas that have had environmental degradation, or areas with high rates of chronic disease. So we're trying to balance all these things when we come up with these phases and the allocation systems, which is really who stands where in line for the vaccine. All right, so this is the Chicago allocation system. And I'm using it because it is basically based on the CDC one that was released. There's one small alteration. And I will point that out to you. So one thing to notice is there's no children in here. The vaccine is not recommended for anybody under the age of 16. We did not test it in anybody under the age of 16, which is one reason for it. We also did not check it for any pregnant people. And so if somebody is pregnant, we urge them to talk to their physician about whether they should do it or not. Because there might be implications for the developing fetus that we do not know about because we didn't look at this. Okay, so since mid-December, we've been in phase 1A. That has been healthcare workers and residents of long-term care facilities, nursing homes. We just entered phase 1B here in Chicago. Some states got there sooner, some states aren't there yet. The recommendations from the federal government were guidelines. They don't have any force. And so states were free to adopt this and not adopt this. So whereas R1A were healthcare workers and long-term care residents, in Texas and Florida, they gave it to anybody over 65. So if my parents are getting their second dose tomorrow and their healthcare provider has not yet had it because they didn't give it to healthcare providers first. They did no allocation. Of course, these are places that people like to retire because they're warm weather. Although why anybody wants to go to Florida is beyond me. My family's been here for 20 years and I still don't get it. Um, but it's kind of been a nightmare. There's no very little organization. Actually, the Florida distribution system is done by campaign donations to the governor. The only entity that can distribute vaccines in the state of Florida is Publix, and they donated money to the governor's reelection campaign so that they could have the exclusive right to this. And people think Chicago's corrupt. Okay, so phase 1B are our essential workers. These are frontline essential workers, people who are public facing. So you're looking at grocery store workers, people who drive delivery trucks, sanitation workers, people who make it possible that those of us who can work from home, and those who don't have to work can get delivery and don't have to go out, right? And Chicagoans over the age of 65. Here's the one difference. So the CDC recommendation was age 75 or over. The state of Illinois decided that it would be 65 and over in order to deal with inequities. There are fewer people of color who reach older ages because of their disease burden. So by making it 65, they would include more people of color. And I'll talk a little bit about the inequities that have happened in the rollout and in the way that the disease has affected populations. And also non-healthcare residential settings. So these are things like prisons. These are things like treatment centers. So these are places where people live close together. Their spread is very easy, but they're not long-term care facilities that have been dying, but they're places where spread is very likely. Phase 1C is tentatively scheduled to begin the end of March. Nobody believes it will actually begin on time. I'll show you why in a moment. And this will be all other essential workers, so everybody not in these first two groups. And then Chicagoans 16 to 64 with underlying medical conditions. So you have to have a condition that puts you at risk for COVID-19 of being, again, hospitalized or dying. So obesity, potentially people with cancers, people with lung disease, people with diabetes. These are all diseases that make it worse if you get infected. And then phase 2 is everybody in the city over age 16. And again, except for that 65, 75, this aligns with the CDC guidelines, the federal guidelines. So what does this mean for, how did they make these decisions based on the sort of what I laid out as the ethical foundations? How did they decide who got into one phase? So this is basically how the decision-making happened. So for phase 1A, it was people at greatest risk of dying. Let's save the most lives. And as well as people whose job it is to help the sick. Because if our healthcare workers got sick, they're not easily replaceable. And if they get sick, then who's going to help the rest of us? Plus, they have been putting their lives on the line. They have been staying away from their families. And so as a society, we owe reciprocity. We owe them for putting themselves at risk for us. So for those two reasons, this is why this group was put in 1A. The second phase, 1B, is people who are greatest risk at infection, who we need to keep society functioning. There has been an addition to this here in Illinois, which is elected officials, because they believe they are necessary to keep society functioning. I can debate that, but they put themselves on this list. And then the next group that are at the highest risk of death. Phase 1-3 is, again, the next group at highest risk of infection and the next group at highest risk of death. And then phase 2 is basically everybody else for which this is FDA approved. There is an FDA trial that just filled looking at this in adolescents and teenagers. And so probably in 3 to 6 months, we'll have the results of that. Okay, so this is how the decision was made about how to put people in these different phases, except in Florida and Texas and a few other places where it was all politics. So what does this mean for a place like Chicago? Well, our 1A population, we actually have a lot of healthcare providers, and it's 434,000 people. And remember, it's 2 doses, so 860,000 people. In phase 2, we're looking at just over 700,000 people, or 1.4 million doses. Phase 1C is 500,000 people, 1 million doses. Phase 2 is 430,000 430,000 people, 860,000 doses, which comes to just about 2.1 million people, 4.15 million doses. There's about 2.8 million people living in the city. Those would be the rest of the under 16s who are not yet approved for getting the vaccine. We get 34,000 doses per week in the city of Chicago. So, phase 1B alone, at 34,000 doses a week, assuming that's constant, which may change if Johnson & Johnson gets approved, if there's a slowdown in the pipeline, if we can't get one of the materials, if a batch is spoiled, all of these things can happen, could slow it down. It would be 42 weeks before we could get to 1C. This is why I'm skeptical of the March 29th start date, that in a month we'll be there. And we've barely started giving it to people in 1B. In fact, you can make reservations now if you can get through, but very few people are actually getting it at this point. So that's my skepticism on the timeline. All right, so now we have the Biden plan. Things have changed in the last week and a half. And this is, he put this out on his first day in office, and it was way more than anything had happened in the last year under the previous presidency. This is basically some goals, some large concepts without a lot of specifics. You know, we want to protect those at most at risk. We want to make sure we get rid of inequities. We want to expand emergency relief. We want to use the Defense Production Act, and we want to really get the public health elements in place that we've been using that a lot of people haven't been using. So these are very basic things. This came from the New York Times. It's very easy to find this. But what has he done specifically in his 10 days in office? Well, he's set a goal of giving 150 million doses in 100 days, his first 100 days in office. You may have heard originally it was 100 million doses, which would be 1 million doses per day. However, that's kind of what we were doing already. So he upped it to 1.5 million doses a day to give us something to work for. He enacted the Defense Production Act, which is great, but now it doesn't happen overnight. So now the administration has to negotiate with companies about how much they're going to pay, about what it'll take to get them on board with this. That will take several months. The kinds of things that we can increase production on are masks, gowns, swabs, reagents, pipettes, syringes. These are important. There's limitations on the materials though. So we can only do so many masks because the material for masks basically comes from China. There's really very few other places in the world that make it. 3M has a small factory in the United States, but it doesn't produce a great deal of it. So we've got to work on that. Syringes are important because you may have heard a little bit about getting the extra dose out of the Pfizer vials, but that extra dose comes from a special syringe, and there aren't very many of these. So if we can make more of these syringes, then we can suddenly increase the number of doses we have without increasing production. So that's something they're working on. He's establishing a pandemic testing board so that there's sort of uniform testing across the United States. One of the interesting things that came out about the test being used here in Chicago is that it's not terribly accurate. It has a high rate of false negatives, which means a lot of people who are getting a negative test result actually have the virus, but it's not being picked up by the test. He has instituted a mask travel requirement. So if you are traveling interstate in a plane, train, and a bus, you must be wearing a mask for that entire thing. And it was expanded on Friday to be any form of public transportation. So if you want to take a bus within the city, if you want to take an L train, you must be wearing a mask at all times. Pretty much the only way you can travel without wearing a mask is on foot or in your own car. They're going to coordinate data collection. So it turns out, not to anybody's surprise, that there wasn't much data collected on COVID by the previous administration. In fact, Chicago was the first public health department that found that there was inequity in racial characteristics of the disease, that it was hitting Latino and Black communities far higher rates than it was other communities. So now we're going to get national standards for collecting data. He's creating a health equity task force to look at these inequities. They're coming out with guidance for schools and workers, things like manufacturing plants and slaughterhouses. How do we make people safe here? In the previous administration, we didn't even try. And he's going to try and release more money for treatment, testing, distributing vaccine. This will depend on Congress, and Congress is not very functional at the moment. They're trying to have a few things out, and they've got a small trial starting this week. So, but these are the actions that actually have been taken in the first few days of the administration, which is more action than was taken in the previous year. Okay, so here's some of the inequity going on. All right, this first graph here is a distribution in cases in the city of Chicago. And this stands for all cities throughout the United States. You'll find this in Portland and New York. You'll find this in Houston. You'll find this everywhere. Los Angeles. So the darker the color, the more cases in that region. So you can see the loop and West Loop and South Loop have very few cases. The rest of the city has more. You'll see where deaths are. So again, there's very few deaths in those same areas: Loop, Lincoln Park, Gold Coast, West Loop, not a lot. You have a lot of deaths on the west side and a lot of deaths on the south side. So these are Hispanic deaths. These are Black community deaths. So there's big differences. Rogers Park is up here. Oops, that wasn't supposed to happen. So you'll see that's where the deaths are happening. This last one, this is where we're distributing vaccine. So the darker the blue, the more vaccine, that's the more larger percentage of the population. This is by zip code again. So you'll see where we've distributed the most vaccine is in the Loop and West Loop, exactly places people aren't dying or getting infected. That it's the coast, right? So it's right up and down the coastal neighborhoods. That's where people are getting it. These areas are interesting because this is where most of the first responders live in the city. And so they're getting it. But again, if you look, they don't have very high rates. Where we do have high rates of death and high rates of infection, we're not giving much vaccine at all. Now, in part, this is because phase 1A is healthcare workers, and healthcare workers tend to live in the north side. But it does show there's an inequity in how we're distributing. It also shows that medicine has a race problem and needs to bring in more people of color into its ranks. So this is some of the inequity going on. There's also an interesting black market, or a gray market is probably more accurate. So if you can afford it and you have the ability to travel, the state of Illinois has said that you can get your vaccine in any county in the state. You can go anywhere. So if you can get to, and I've been hearing of people who were able to get through and go to Peoria, and the Walgreens there had a space. So they're driving to Peoria in order to get it. Not everybody has that ability. Not everybody has a car. If you own more than one home, and it's in a different state, you could actually get on the list for multiple states. So Florida has had a problem with this. A lot of people own homes in Florida that are their second homes, they're snowbirds. And so originally people were getting, because Florida started with over 65, whereas say New York and Chicago started with healthcare workers. You own a home in Florida, you spend 5 months a year there. So you got on the list there. You can fly down, you can get your vaccine, and then you can come back to New York. So Florida stepped up and said, okay, no, you have to be a resident. And they define a resident as somebody who spends 181 days a year minimum living in Florida. This got people very upset. But it meant that people who didn't actually live in the state were getting the vaccine from that state and taking away from their supply. There are boutique physicians. So these are physicians that you pay a yearly fee to, and you get access to them 24/7. They come with you to the hospital. It's actually the way medicine used to be, but you pay a fee for this, and they are finding ways of getting vaccine for their people because they're demanding it. And then it turns out academic medical centers have been part of this black market as well. Now, because of the freezer requirements, the academic medical centers are some of the few places that have these freezers. And so they basically have the supply for a community. But instead of giving it to the community, what a lot of the centers did is they went, okay, we gave it to all our healthcare workers, but we still have more here. So rather than going on to the next phase, they just gave it to their own people. So they gave it to the accounting office who was working from home. They gave it to researchers who never saw patients. They gave it to people who did ordering or worked in the business offices. They gave it to students who were just working in a laboratory and were very safe. So there's a lot of uproar now that these academic medical centers abuse the trust that was putting in them for storing the doses that were supposed to be for an entire community. These are concerns. There are also some medical centers that gave it to members of their board and their high donors. They would call them up and be like, hey, you know, we've got some extra doses. Why don't you come in and do this? Which again is skipping the line. So when I say gray or black market, it's people skipping the line, people getting doses that they are not yet entitled to. So we're seeing a bit of this going on. Now, that's in the United States. There's a lot of inequity going on throughout the world as well. So this is looking at when countries can expect to start vaccinating their population. The darker green and the greens are in 2021. Yellow or orangey is 2022 and red is 2023. There are some countries that have fewer than 25 doses for their entire population. The second is how many doses have been administered. So if we look at this, we can see the United States and China have given the most. They have bought, basically what happened is a lot of the high income countries pre-bought hundreds of millions of doses of the vaccine at higher prices. So a country like Zaire could never get in on this because A, they couldn't afford it, and B, they didn't have the power. They didn't have enough money to make this happen. Now, in some ways, like the European Union has a lower population than China, so it's not surprising they have less. But if you see where it's gone, US, China, European Union, UK, Israel, UAE, India, Germany, Italy, France, Russia, and then Mexico, Bahrain, it's the bottom, and these are all wealthier countries. What if we look at internationally countries by whether they're low, middle, or high income according to the Food Bank, the World Bank? So high income countries, most of the ones I just talked about, are 16% of the world population. They have received almost 78 million doses that have been produced. Middle income countries, which are India, Myanmar, Ecuador, Indonesia, for example, have 76% of the world's population and have gotten a total of 2.3 million doses, which just over 2 million going to India, which of course has the largest population. And low income countries, which are 9% of the world population, have gotten 0. They haven't even been able to start inoculating. So we can talk about the inequity happening in the United States. We can also talk about global inequity in who is getting the vaccine. And it's very simply that we all pre-bought. The United States went to 6 different companies, gave them billions of dollars to sort of bet on who would come out with a vaccine that would work. And we pre-purchased many of the doses, the ones that we're receiving, which is why the doses we receive today are free. There's a charge for the syringe and the alcohol and the space and the person who's giving it to you, but the actual vaccine is free because the federal government has paid for it. Not so in other parts of the world. We still have a lot of challenges. So vaccine hesitancy is a big issue. And some hospitals are reporting that 25 to 50% of their healthcare workers are refusing the vaccine. A friend of mine does ethics work in SUNY Downstate, which is Kings County Hospital in Brooklyn, where a lot of the healthcare workers, especially the nurses, come from the Caribbean, and they're all refusing this. They don't believe in it. They think it's been too fast. They think it's putting poison in their bodies or microchipping them, a lot of the conspiracy theory stuff. So it means that we might get through the phases faster if half the people are refusing it. It means we're not going to get out of the pandemic anytime soon, though. Communities of color have a lot of historic reasons for not trusting the federal government or public health or the medical care system. And so they have high rates of hesitancy. UIC is doing some research on this. The Chicago Department of Public Health is starting an education campaign, but you can see this. This happened Friday, I believe it was, reported yesterday. So Dodger Stadium, which is a mega site for vaccination in Los Angeles, which has the worst outbreak going on in the world right now. They had to shut down Dodger Stadium for an hour because there were anti-vax, pro-Trump protesters that basically shut it down. And they were holding up signs that said vaccines don't work, that vaccines are poison in your body, and that COVID-19 is a hoax. It's not real. And delayed things for an hour. The other challenge we have new variants. So there are 3 new variants that have been identified that are having spread: the UK, South Africa, and Brazil. The B and Ps are their technical designation if you come across it. We know that the UK has told us that their new variant is 50% more infectious. So you've probably heard, and Fauci says he believes that data. That is why there's a new recommendation when you wear a mask to wear 2 masks. It's a double mask now. You put your cloth mask on the inside closest to you, and then a surgical mask or on the outside, unless you have an N95, and then it's a different story. The UK is also reporting that it's 30% more deadly. This is a number that the United States is checking the raw data on before they're backing up, but that is the UK report. The South Africa variant, the challenge, but we also know that both Pfizer and Moderna work against the UK. The South Africa variant, or the ZA variant, the vaccines we have are less effective, significantly. I mean, they still work a little bit, but only half the time instead of 95% of the time. We don't know much more. We know it's more infectious. We don't know if it's more deadly yet. The Brazilian variant, we've had the first case in the United States. This one has pretty much been in Brazil. We know very little about it. None of the vaccines have been tested against it yet. What's really disturbing about this one is the city of Manaus in Brazil, which is a city of about 3 million people in the middle of the rainforest, that 75% of the population of that city got COVID-19 in the spring, 75%. Because their government didn't allow people to wear masks and they didn't do anything about it. Brazil had almost a worse situation in the United States. And what we're seeing in this new variant is that those people are being reinfected now. So the concern is that this one, that having a vaccine may give you 0 protection against this. What are the drug companies doing about this? Well, they are making new vaccines. Like I said, it's actually pretty easy once you know the DNA code to sort of insert that strand inside of your viral vector or inside your little fatty pocket. And so they are creating booster shots, as they're calling it. The risk with this is that we have a very fixed production cycle. Unlike, if you want more ventilators, you can take a transmission factory for a car and convert that in pretty fast. You can't necessarily do that for a biological compound because these are very delicate. It can be hard to get some of the materials we need for making it. The temperature, there's just a lot more that has to go right. So we can't just ramp up production very easily or quickly. And so if we're going to now be creating boosters, we're going to be taking away initial supply for people to get their regular injections. And looks like you probably need both. So this is an issue that we have to think about, we have to deal with, and we're just starting to comprehend how bad this is. In fact, the South Africa and the Brazil variant were just found in the United States this last week. And we do have UK here in Chicago. If you are in Chicago or whatever city or state you're in, every place that gets an allotment from the federal government is having some sort of a sign up so that you can be informed when you come up and how do you sign up and things like that. In Chicago, it's called COVID Coach. So it's covidcoach.chicago.gov. It's a really weird sign up. It sounds like you're signing up to get a test to see if you have COVID. You are not. There's a certain point where there's a little box saying that you just want to be on the vaccine list and you don't want, but you've got to get through all this thing of like, do you have this symptom? Do you have this symptom? To get there, and you will get text messages. So last Sunday, I got 3 text messages saying that we were entering phase 1B, and if you were over 65, you could sign up with your healthcare provider or with Walgreens or CVS in order to get this. So that's the way we're going about it. And that's it. So you probably want to scream and feel like COVID is coming down all around you after this discussion, but questions, conversation.
Go for it.
That's what I got. I will stop sharing.
Wow. Wow. Well, that was fun.
I spent a lot of time depressed. I really do, because when I realized I probably won't get my injection until like September, yep, that was pretty depressing.
Penelope, unmute.
So there was a really interesting, which I suspect you saw, interview with Melinda and Bill Gates that the Washington Post ran last week. And I mean, what they're, unless you're going to tell me something else, which I'd like to hear if it's true, I'm really impressed by them and what they are doing on many things. One of the things that Bill Gates in particular, I guess they both talked about, when you're talking about ethics and the rest of the world, I mean, selling to Americans that none of us is safe unless all of us are safe is a big deal. And one of the things that doesn't get talked about much is the fact that the more this runs wild, for want of a better term, the more likely variants are to emerge because you have just more people getting sick. When you're talking about equity, and you looked at the richest countries, there is also the United States, perhaps the poster child for rich country, has this outrageously high rate of infection and death. So it's not, to me, and I don't know how you do this when you come up, I mean, somebody's coming up with an algorithm of some sort, and I don't know quite how it happens, but it seems that it isn't just rich, poor. I'm pulling out of the air, but I'm suspecting that the rate of infection in Zaire is substantially lower than it is in the United States.
Is
As a per person basis, not just adjusted. So how do you come up with an equitable distribution that A, reflects the first idea that none of us is safe unless we all are, and B, just looking at the income level of a country may not give you they should be sharing it with the poorer people, or they need it, may not give you the right answer. How do you do this?
Well, we've got to remember that income and wealth are two very different things, right? So, places like Nigeria actually has very high income, but has low income but high wealth because it has such oil reserves, right? So we've got to realize that there's some balance there. When it was spreading to Africa, everybody in global health went, this is going to be a nightmare. This is going to be a disaster. It's going to be HIV all over again. And it didn't happen. And why didn't it happen? Because we in the United States and in Europe believe in magic bullets. We don't have to deal with things. We don't have to diet. We don't have to exercise because somebody's going to come up with a pill that's going to cure everything. But when you live in a place where you go, well, even if they came up with a pill, nobody's going to get it to us. You have to believe in the preventive measures. And so they wore masks and they distanced and they washed their hands and they didn't travel. I mean, they don't travel much anyway. They did all the things that we should have done so that we didn't have a quarter of the world's cases. So that's part of it. There is an international, so one of the solutions to this problem has been an international program called COVAX, COVID Vaccine Alliance, that the United States didn't join until last week. And the idea is that governments, the Gates Foundation is a big part of this, has given money to purchase vaccine to give out to people in low-income countries. So it's a balance of, because Pfizer and Moderna are not, they give away some doses, a large number of doses, but they're in this for the money. Let's face it, it's capitalism. And so there is an international effort to buy doses that can be given out to other parts of the world. That's the basis for doing it. Which phase allows teachers to be vaccinated, Merle?
You answered the next chart you showed.
Answer that. Okay. So the interesting thing is university professors. I cannot get an answer out of the city of Chicago where we fall. We are not 1B where teachers are. I know that for sure.
Why would that be?
because it was not given in the CDC guidelines. So every state and every city is doing it differently. So in some places are giving it 1B, so we'd be up now. The city of Chicago and the state of Illinois have not. I have been on them. I have emailed, phoned, asked questions in webinars. Nobody has given me an answer, which means that we're probably phase 2 along with everybody else, which will make it very difficult for us to open in the fall. Yeah.
I have a question. I'm sorry my screen is off because I'm eating something. I'm
It's okay.
on screen, so sorry. 2 or 3 days ago on CNN, not Sanjay Gupta, the other doctor who comes on there, offhand mentioned something about Crohn's disease as a side effect. I'm going to take the shot no matter what it is, but I was surprised. I'd never heard that before. Could you speak about that?
I haven't heard anything about that. A side effect of the vaccine or of COVID infection?
I don't know. There was just something that he had said is one of the doctors that comes in the afternoon with either Pamela Brown or the other speaker. And he said something to the effect, I don't know his name, but he's one of the 2 doctors that is on route on CNN. He mentioned it, side effect.
What I can imagine is that they were probably saying that something like Crohn's disease might be a condition to put you into that phase 1C, where you have, it's probably one of the diseases that are existing conditions that make COVID worse because it is an immune disease. But no, I haven't heard or read anything, and I just got a virology update on Friday, so I think I would have heard if that had been something more. I would say take everything you read in the news or hear in the news with a little grain of salt. This stuff changes fast. Like these slides, sometimes I have to change these twice a day. Things change that fast.
I just send information to Jack for input. But I've got a question in terms of Israel, who's doing it better than anybody else.
They are.
And
yes and no.
Huh?
Yes, they are, and no, they aren't.
Well, I know that. But, we have our crazies in Israel too. But it seems to be a semi-contained population.
Right.
With scientific underpinnings.
Yep.
Science is important. I'm reading some statistics about what is coming out now, that a percentage of the population has had 2 shots. And now there are differentials. And I would assume there's going to be a hell of a lot more data coming out of Israel that's useful. What will that be?
So the data that we've gotten out of Israel so far, and you've got to realize you're dealing with a small population, isolated, right? There's not a lot of flowing over borders. Who believe in science for the most part. There are populations not. There's some question about how they've been doing in vaccinating the Palestinian population. That's another issue. What the data they release is that even after 1 shot, they noticed a huge decline in transmission of the virus. So again, it's 2 doses, and it's also a fairly wealthy country compared to many around the world. And so they found that if they, I think it was when they hit like 50% of the population being vaccinated, even with just one dose, that their infection rate dropped. So that's the message we've gotten so far out of their data. And there will be more coming. But, they're a smaller population in a wealthy country, so they were able to buy enough. It's easier to buy enough doses for a smaller population than it is for 330 million people. But it's exciting what's coming out of there. It's really hopeful.
Plus it's organized. There's national health.
That makes a big difference.
Yeah.
Everybody has health insurance. It doesn't matter who your employer is.
Right.
Huge difference. Yeah.
I was thrilled to learn that my sister and brother-in-law have both received 2 shots. My nephews, who are in their 40s, have just received the first shots.
Right.
And
we have no distribution system here.
I know.
Because we don't have an organized, there is no U.S. healthcare system. It's a conglomeration of a bunch of different stuff, right? We've got,
Is any of this going to change post-pandemic, or are we a bloody country of individuals?
I mean, look what it took to get the ACA and then to keep the ACA, right? And that's basically just giving money to private health insurers. I don't know. I'd like to think that we have the opportunity for doing something like Medicare for all, which would bring us closer to the German system, where you have private hospitals and doctors, but public health insurer. I think as long as there is, that health insurance is a huge industry and lobby and throws a lot of money at politicians, and the same can be said of the hospital system. Like, we have to get money out of politics. Most other countries don't have money in politics. Like in France, France is amazing. When you have an election, you are allowed to campaign for 6 weeks. And it's mostly public money. They do not take money from large corporations. So none of this 2 years of craziness and pumping in millions and millions of dollars, like, it doesn't happen. I think a lot of this is Citizens United that allows corporations to basically pick who our politicians are. So I would like to think that there's opportunity here. I've written that there's an opportunity here. The question is, are we going to take it? We have had plans before. We had the ACA, I would not say is a universal health plan. We had the Clinton plan, which went absolutely nowhere. We had a plan under Richard Nixon, went nowhere. We had a plan under Roosevelt, went nowhere. We're not new to this.
Well, it was interesting years ago, the Stephen Covey book about 7 habits.
Mm-hmm.
And he was talking about, we as Americans pride ourselves on independence. Gary Cooper, shooting it out with the bad guys.
Mm-hmm.
When truly the highest evolution for us as humans is interdependence. And, I found that an interesting statement, especially what I'm watching now.
Well, if you look at the founding of our country, we were founded by people who thought
misfits.
Well, they thought Europe was too liberal, and they didn't want to have to deal with other people. And so they came here with this idea of independence. De Tocqueville came and he said this amazing experiment. People have freedom. They can build themselves. On the other hand, if they don't succeed at building themselves, they're lost. And he didn't think our experiment would be terribly successful. There is a philosopher named Charles Taylor, not the mass murderer Charles Taylor, but a philosopher. And he said Americans worship at the feet of individualism.
Mm-hmm.
And he said, there is this concept of the individual, and it's given us amazing things like computers and vaccines and like amazing stuff. But we worship that that we are individuals and only we can make ourselves, which ignores the fact that we share the expense of schools, and you drive on roads every day that are paid for by public dollars. You don't build your own road every time you need to go somewhere. That would be unreasonable. And we rely on public health to make sure we have clean water and safe food and all that stuff. But we don't, when people go, I'm a self-made man, like Donald Trump did after inheriting $400 million from his father, like, it's this story that we are self-made. And so we purposely go out of our way to deny the fact that we are reliant on one another. And so we look at disease as an individual failing and as a moral failing, which comes from our roots. The same people who said, we don't want anybody else. It was, you were judged by God individually, not on your works of what you did to other, because God already decided who was going to heaven. And so you had to act as if you were one of the chosen. And this idea from pre-colonial times is still influencing our politics today. Calvinism is still our major way of working. And so you're supposed to act. Like, think about the gospel of wealth, which is the whole evangelical movement. And you are a sign of the elect, of being chosen by God, is that you have a lot of money. It doesn't matter how you got it. It doesn't matter if you killed a bunch of people or enslaved them. if you had money, you're part of the elect. And that's still like people with Donald Trump. Why are people buying into it? Because they view a strong man with a lot of money who tells the story of being self-made, even though those of us from New York know he's not. And he just basically got this way by inheriting money and never paying anybody who worked for him. That this is the idea of the self-made person is a myth. And so when you have a society like Israel, Scandinavia, most of Europe that embraces the fact that, yeah, we're in this together. Viruses don't care if you live in Chicago or you live in Naperville. They don't care if you live in Illinois or Michigan. They don't care if you live in Canada or the US. It's airborne. It doesn't matter. So, yeah, I think it's part of our culture, it's part of our history, and it's definitely part of our politics.
I have another question if no one.
Please.
It's more on your subject matter, ethics. I think perhaps if they taught ethics in school or started to, a case in point, you talked about philosophy. I believe it was Michael Higgins, who's the president of Ireland. He pushed philosophy in the school systems in Ireland. And very recently, that predominantly Catholic country voted a homosexual, is it Taoiseach, their prime minister, that's what it's called. That's what he is called. And I think they're studying data that it's changing the outlook of a very, very predominantly Catholic country. Perhaps we talk, I'm very curious, the idea of having philosophy and ethics taught in school, because you can subtly change somebody who feels what you said, an entitlement, I made my money. It's not the question of data, because if it were data, we have enough evidence in this evidence-based world. We certainly ignore the evidence, because the evidence question is that it's more how Michael introduced you compassion. You cannot take a pill for that. Most of these Republicans, as you call them, or there are probably enough Democrats also, who are immune to compassion. You cannot put that through a shot. Most probably would have to be, I don't know, introduced in school systems. If you're only studying data, STEM education, you're cutting that off more. I would suspect 10 years from now, the school systems are now just teaching science, got nothing to teach with the thing about being human. People will get even more. I'm just going to use the term Republican, but I think there are many, many kinds of Republicans. I'm just saying, this thing of me only. Does that make sense? Are you seeing teaching of ethics and philosophy in school, or even colleges, or business, lack thereof?
Yeah, I I think it would be great. I mean, the traditional education that was, in the UK, was in Ireland, was even available to elites in the United States was, you studied philosophy from very early ages. You studied Greek and Latin. I'm not advocating that, but so that you could read Aristotle in the original, right?
Penelope studied
Penelope.
Greek so she could.
Oh, okay. Although ancient Greek is a little different than modern Greek. So you could, yeah, I think it would be great. I actually did my training in anthropology. I didn't even know that existed till I went to college. Like there's so many things that we don't embrace. The emphasis for a while now has been on STEM, science, technology, engineering, and medicine, to the exclusion of the liberal arts. And I think a lot of what we are seeing, the lack of critical thinking, the whole QAnon conspiracy, are people who just don't want to or can't think for themselves. And yeah, so I am definitely I think we need to embrace and bring back a lot of the liberal arts in education. And the challenge with that is they can't be tested in the same way. If I teach you, if I teach you the Krebs cycle, there's a right or wrong. I can ask that on a multiple choice exam. What is Aristotle's notion of the virtuous good? That requires an essay, and essays are harder to grade and more subjective. So they just don't put it on the exam. I mean, before I moved here, I was taught philosophy and humanities in a medical school. And one of the things I had to do was figure out how do you make a multiple choice exam with yes, no answers for philosophy. And it was hard.
Craig, I think there's another more potent reason why this idea, which I think is a great one, will not be implemented in the foreseeable future, is that this is clearly a leftist socialist commie plot,
Right.
to inculcate our young people into thinking like humanists, when in fact that is the last thing that the governing powers, especially in the Republican Party, who have gotten as far away from ethical and moral behavior as you can get recently, uh, and who have spurned the one quick way of improving their status and trying to bring their followers along with them in after the rebellion of the 6th of January. They're not. Just think of what that document 1776 that was put out by the Trump administration. Talk about the ethical bending of the history of this country to even defend the institution of slavery. I mean, on and on and on. You, you know, we're all sitting here. You know, we're about as red as you can be if we think that. Which is funny because, of course, communists would never even dream of doing anything like this. But they're not going to. They're not going to do this. In fact, they would like to even restrict the idea of moral teaching of other than the predominant evangelical Christian ideas about how this world should be ordered. Calvinism, now that might actually get a lot of money behind it in order to teach that, or you know,
Well, it
that
has.
succeed. I mean, that would be a success.
that's
I
the
think
dominant.
politically, it's impossible. I
There
mean,
are foundations created to teach the Ayn Rand objectivist curriculum in schools, right? Which is all about me, me, me. So here's the irony, though. So all these people who are pushing the STEM, pushing the getting the liberal arts out, not teaching critical thinking. Ted Cruz is a public policy major from UT Austin. Marco Rubio was he was a poli sci major at the University of Florida. Ted Cruz is a Latin major.
Josh Hawley is either magna
know.
summa from
No.
Stanford in history.
Yeah, no, unfortunately, he's one of our more embarrassing graduates.
but you see, these are the very people who know the power
Yeah.
and where all this will lead. If in fact you do educate the youth of this country in this way, and they are in a unique position to understand what this means and to fight against it because it doesn't coincide with their political goals, which is essentially to maintain a minority power, a party in power.
Mm-hmm.
And one of the ways to do this is to do away with critical thinking, teaching critical thinking. Now, I suspect that they also understand, being the highly educated, that critical thinking is necessary for a certain subset of the population. For example, industrial physicists, engineers, physicians, or medical researchers, people who are making, money making vaccines, et cetera, et cetera. But they don't need to acquire these talents as youth, which is a mistake, by the way, but they need somebody, somehow, that subset of future elite scientists
occupations where you can't make mistakes
are going to
I hear someone put it.
Yeah,
occupations where you can't make mistakes
are going to be
you
taught
have to
critical
educate
thinking.
the people critically.
Right.
So
But
what's
not
interesting
the
is
masses.
even the way we teach science has changed on the PhD level. So we used to teach, people getting PhDs in science. It was follow your passion. It was investigate things just because they're interesting. So think about Watson and Crick trying to figure out the structure of DNA. When they figured it out, there was absolutely no use for it. It was a puzzle, it was an intellectual puzzle, but it was another 30 years before anybody found out there was some use for this. The vaccines, the mRNA vaccines, the work done for that was done 20, 30 years ago. It didn't have any practical application. They just thought it might be interesting. The way we are training PhD researchers in sciences now is that you should only do research on things that can go to market. If you can create, so it's not about basic science. It's not about discovery or following what seems interesting. And the government, we just came out of this period of only funding things that can lead to marketable products. And when I was at the University of Texas, and I was working in a lot of this area of training graduate students in the sciences, we would do, it's called technology transfer. It's called translational science. You only study things that you know will be successful in the market. And if it looks like it won't lead to, if it's an interesting thing, but it won't lead to a marketable product, you are supposed to abandon it and go on to something else.
Well, and Texas is saying now, I don't know whether they've implemented this or they were just talking about it, but that every college student should be given the information of how likely his major was or her major was to lead to a lucrative profession, so that it wasn't that you could, you didn't tell them not, it wasn't that you told them not to major in anthropology, but rather that you let them know that they were much more likely to be paid more if they went into electrical engineering.
Florida took a step further. If you wanted to do one of those careers that weren't really lucrative, your tuition was higher to dissuade you from going into it.
Who said
Florida.
You know, I am usually, what is the word, Pollyanna, but
That's a fallacy.
Yeah,
what-
right. we know you better than that, Shoma.
there are people who have power and huge amounts of money who are investing in humanities. One being, who's that guy from, he owned the Texas basketball team.
Mark Cuban.
He,
Yeah, Mark Cuban, yeah.
yes, he screams about people studying humanities as an outset. I think I've said before, against the onset of AI, many of the jobs, even for radiology, will be gone as computers are reading it. And then almost everybody who's on the top echelons of Silicon Valley, they're now pushing humanities to be able to think outside the box, because once I'll take a pill for it. So what the politicians won't do, but they're just glorified sheep anyway. If their money funds them, they will forward. I mean, really, Ted Cruz, for all his degrees, they're just low-level cunning, passing as intelligence, highest education, depending on who funds them. But that's the thing about them, they just can be led by money. They swiftly change thing as long as the funding is provided by Silicon Valley or whatever else, because they will need it. The same people who want to have a lot of money, the 1%ers, know full well unless there's money provided at some level, it will be revolution. So to tamp that down, the UBI might be looked at better. And they are promoting highly humanitarianism, a studying of the humanities. But that's, I find that odd. What did you say? Some of the people who got degrees in humanities, Richard Spencer, the head of alt-right, has a master's in humanities from the University of Chicago. I don't think that's a panacea. Spirituality comes into it. Ethics are all around you. I really think those things matter, not just learning a lot of facts to show like, I'm so smart, I can be a good conversationalist. That's why I think ethics is really good, not just dry humanities. Ethics matters deeply.
I would agree. That's why I made it my life's work. As I tell my students, I don't care what conclusion you come out with. I care how you get there. Show me your thought process. Show me how you made logical step-by-step decisions.
Craig.
I could argue that poetry is important in that I taught high school in a private school in Southern California in 1965, right out of college. And it was John Birch territory, which
Oh,
but one of the things, and I was too young and stupid to realize that I was putting myself at risk by doing this. But one of the things I did was I went down to downtown Los Angeles and picked up communist propaganda and brought it back to have them. It was awful propaganda, really gross stuff, but it was brand new. And these were elite kids. This was a private school. It was brand new information to them that language could be used to affect your emotions and how you felt about something. It was brand new. And poetry is one way of getting at that. And propaganda was another. I had them write propaganda, which again could have had me strung up probably, but this was a school, just side note, this was a school in which parents complained because a social studies textbook showed a line outline map of the United States superimposed on one of Russia. of the Soviet Union showed that Soviet Union was larger,
Mhm.
and that's un-American.
Wow, because it's the exceptionalism. that goes
So,
against
but the
that.
idea that, but I'm actually serious about poetry. The idea that language affects how people
Absolutely.
respond and how people, you listen to any politician, not just the last administration. And if you have that kind of awareness, you will listen differently than if you don't.
So my PhD is in medical humanities, which has evolved now into health humanities, and is the idea that we should be training physicians and scientists and nurses in the humanities. So I taught poetry and literature and art, and as well as philosophy and religion and ethics to these science students. And granted, it was like 10 hours over 4 years that they got of this, but it was which is why I moved to undergraduates, to realize I could do much more work here, give them an inoculation into the med school experience. But I completely agree. And, we can have them, my pandemic literature course was like, let's look at how people have dealt with this in the past. We read poetry that's being written by nurses on the front line in COVID. There are collections out there. And, the students said, I don't think I really realized how the emotional toll that healthcare providers are taking in taking care of us during this. And yeah, I guess I really should make sure I wear my mask. So I
Craig,
completely agree.
Craig, a question, because we came away from your presentation
We can move back.
going, wow, but there's a celebration there
Mhm.
that we're not emphasizing. My God, a year, and we already have pretty much 4 vaccines
Mhm.
that are 2 are ready to go in the States.
Mhm.
That's amazing.
It is truly amazing. We've canceled Merck canceled the 2 that they were doing because their numbers weren't very good. But yeah, in a year, we have half a dozen vaccines that are effective, which is incredible. Polio took 6 years to get. So it's not fast. There were no corners cut. There were 2 things done to get this fast. One is we use 21st century technology, right? We have a whole genetic biology now that didn't exist before. And we have an understanding, and we know a lot more about the immune system. So that's part of it. And the second part of it is we used epidemiology to our advantage. So a normal phase 3 trial might have 1,000 people. A large one might have a few thousand people in it. And you follow them for a year or 2 to be able to find out what the results are going to be, what the reactions are. So that would be a normal trial. But what we did was so you can either have a small number of people, expose them to risk over a long period of time, or you can have a large number of people exposed to risk over a shorter period of time. And so for the first time ever, we did the latter. So these trials, instead of being 1,000 people or even 5,000 people, were 50,000 people. And that's why we were able to do the trials much faster than we normally would.
How did you get people to sign up with
Wasn't
an
hard.
an illness that could kill, an illness that could be long haul? They're amazing.
There was a waiting list of people wanting to be involved in these different trials. You can still become involved in trials. There's still trials being done today. I had some friends, their teenagers wanted to sign up just 2 weeks ago, and they got into the trial. You can go, there is a trial center right here in Andersonville in Chicago that is still Great Lakes Clinical Trials. They're still taking people because there's more vaccines out there that are being tested. And they're looking for seniors because there wasn't a lot of testing on people over age 65. If you're 65, they're hungry to have you participate. The problem is,
Placebo.
why would you? Yes, the placebo. So you get in, you have a 50% chance of getting the vaccine and 50% chance of not getting it. But we're in phase 1B. You have a 100% chance of getting the vaccine if you sign up on the list. So people are leaving these in droves. That's the problem.
Furthermore, when they figured out that the vaccine was this effective, there was a big argument about whether those who had gotten the placebo should now get the vaccine or not.
There was, and they are.
Intellectually, you would want to, and this is right up your ethics alley. Intellectually, you'd want to keep them in the dark and keep them in with a placebo, because then you will see over long term what happens. But ethically, to not give them a vaccine that is proven to be 95% effective when you have it was a real problem.
And
How did they come down on that?
they took the risk when they
Uh-huh.
didn't know what the outcome would be or if this would be damaging to them. So we came down, as all the companies came down, that they're giving these people a real vaccine. Every one of the
Smart,
companies.
because who would sign up for a trial
Right.
knowing that you were screwed if you happen
Mhm.
forever, if you happen
Right.
to be taking the placebo?
Now, a colleague of mine at, actually, Julie, signed up to do one of these trials, and which was amazing. So we even had like people who were saving lives sign up to be in these trials as well. So yes, it's I would say heroic to sign up to be in one of these trials, because you just don't know what'll happen.
And as it turned out, the friend of ours, and Barbara knows her too, she signed up for the Moderna, and she felt it was her duty to do so. And also that she was a healthcare provider, although that she would be more exposed, but in fact they're not, in a sense, because they're covered from head to foot with PPE. But she also got, but she thought she got the placebo. And the reason is that she had no local reaction to the injection, no soreness of any kind. And that's a mistake, I think, in their design. They should put something in it to cause a slight irritation. That said, she got COVID.
Essence of jalapeno.
Yeah.
Well, there's an ethical issue about causing harm to somebody,
Yeah.
so
She
you know,
got
who doesn't
she
need
got
it.
she got COVID, but she didn't get it at work. She got it through a social interaction that
Mm.
she had no total control over. And now they intend to give her the vaccine. Moderna is going to give her the vaccine now that she's recovered. So, but what drove her to do it was her sense of responsibility and sense of duty, and what she thought was necessary. What contribution can I make to this pandemic? The huge hours and heartache that she was putting in treating COVID patients didn't really fall into that category for her, because that was her job and that's what she should be doing at a baseline. So, what above the baseline as a responsible healthcare provider could she do? And that's why she volunteered.
Amazing.
Craig, I don't know if this is in your bailiwick, but we haven't talked at all about treatment. And there was early great publicity about remdesivir, for instance. We hear almost nothing about that now.
It didn't work.
And I imagine a year into this, there's a lot more known about effective treatment once you get it. And I wonder if you could speak to that.
How's Clorox doing?
Hydrochloroquine, yeah, we're injecting
You should
Clorox.
only take it.
We're putting the wand where the sun don't shine. Yeah, so treatment's been a problem. We have found very few things. So it turns out, we did some pretty heavy interventions early on. Like, one of the weird things about this disease is that you have low oxygenation, but you don't have any of the symptoms that show low oxygenation, right? So you don't get the physiological response, which is really weird. And so following our protocols, we put people on ventilators, and it turned out those 80% of those people died. They did worse on ventilators. It caused a lot of lung damage. So we don't put as many people on ventilators anymore. We put them in prone positions. So we put them on their stomachs. We flip them over, and then we tilt them down, and they do much better. Remdesivir turned out not really to have that much effect. A lot of the antivirals turned out not to do all that much. There are two that are being looked at. Ivermectin, I believe, is one of them, and I don't remember the other one. But the reality is we haven't thrown nearly the money into treatment that we have into vaccines. And so, no, there has not been a huge advancement in treatment.
So
Jack
what
Mayman
was
Warner.
all this stuff that saved certain human beings?
So that's a monoclonal antibody. So this is 21st century technology, where basically, if you had it, there were companies that were buying your plasma. And so you could go in, you could donate plasma, and they were taking your antibodies and refining them into a serum, which could then be injected into other people. And that seems to be the one treatment that is working fairly well. It is hard to do because you can imagine that the processing is pretty intensive. You have to get these donors. You're limited by the donors, the number of donors you can get. It's very expensive. And, but it does seem to work. So basically, like I said, we're priming the immune system with these vaccines to create antibodies. Here, we're just giving you antibodies from someone else. That's essentially how it works.
There's an ad on, I don't know which cable station, which is suggesting you donate your plasma. Is that what?
Yep, that's part of it. So part of it is for that, and some of it is also for research, because we want to take a look at the vaccine. We want to know we want to see what having it has done to your immune system. We want to see if you've had it, do you still have antibodies a month after recovery, 3 months after recovery, a year after recovery? Like, we don't know how long these vaccines will last. One of the things about the mRNA vaccines is it ramps up the immune system, and then you get rid of it out of the body. The body gets rid of it. So these don't stick around. So how long do these antibodies stay in place? We haven't even had them for a year, but it seems like from people who are in the trials that they suspect that you keep your immunity for at least a year. We don't know if it's longer. The estimates now, again, it might take another 2 years, 2.5 years before we can inoculate the entire planet. But we will have now lapped ourselves, because if we need a yearly injection, because there are going to be variants, in a way this acts, I know when early on people were saying it's flu, and then we're like, no, it's not like the flu. But it is like the flu in the fact that it mutates, and it will mutate every year. And we are going to have to get booster shots every year. And eventually this will become one of these childhood illnesses. But like flu, we're going to have to get yearly injections. So if we haven't gotten injections to low-income countries in 2022, and we're now having to produce booster shots for the first world country in 2022, that's a production issue. And we're not even near the point of even thinking about this, never mind doing anything about it. But the variants are showing us, the faster we can get people vaccinated, the faster we will clamp down on spread of the infection, and the fewer variants there will be.
But you bring up an interesting point, which is what you were saying about the mutation rate being like flu, and that's why we need a new one every year kind of thing. That's new. That's brand new knowledge. And early on in, I don't know what month, but the hypothesis was that this was not going to change with any speed at all, that it was going to be very slow, and we had a good possibility of producing, such as the measles vaccine continues to work. The smallpox vaccine continues to work, and flu is a little weird. So to the ethics of this, how are the ethics of really any aspect of this, I would say effective, but probably the more accurate phrase would be screwed up by the fact that the data is changing so quickly, and that what we know, the best knowledge in June is on the 4th of July made moot, and how do you come up with I mean, the idea of the fact that it appears to be producing variants faster than anybody predicted. And furthermore, they seem to be similar.
I interrupt you, Penelope. I don't believe that that's.
Am I wrong?
And I don't like contradicting Craig either, because he's very smart. However, the rate of mutation of this virus is surprisingly low,
Okay.
how other coronaviruses behave. So yes, the fact that we are seeing mutations is not um, mysterious. If we had actually done our job earlier, which is to produce vaccine in huge quantities and vaccinated the world, we might not even have been seeing these. And the only reason we're seeing them is because people are getting COVID. And while they're getting COVID, the virus has the opportunity to make genetic errors and produce a slightly variant. And if that variant is more virulent or is able to infect more people, even the virulence doesn't help it actually, because if you kill off people, it's not good for the virus. But the very fact that the virus is able to infect more people and cause illness where it reproduces, then you're creating a pressure for that variant to become dominant. But the rate of mutation is still surprisingly low. After all, there are 22 million, how many cases, Craig, in the world?
26.
26. Okay, we're not doing enough genetic testing on the viruses. In other words, to track the mutations. But 26 million cases, and they're only identifying 2 other clinically significant strains.
Well, so
Okay.
that's the other point, is like clinically significant, right? So there's 3 strains we're worried about, but I think there's like close to 100 different variants of this that are being tracked, or maybe it's 120 now, variants being tracked
But
around the
I
world.
hear what you're,
And
I
they
hear what
started
you're
pretty
saying.
early.
I hear
They
what
just
you're
didn't
saying, Jack.
change. They didn't change.
Yeah.
The change was not in the spike protein, which is what all the vaccines go after. These 3 changed the spike protein, and that's why they're worrisome.
I hear what you say, but the bottom line is whether it's the virus mutating at a fast rate or not, or whether the way we're dealing with it is such that it has an opportunity, because it's spreading, because people are getting it so much, an opportunity to mutate. It's almost moot, because the fact is there are variants that are coming to the fore.
Well, yeah, but there are 3, right, as we know, 3. And I don't want, what I'm trying to do is not suggest that this isn't serious, which it is. But it's also not as serious as some people may fear.
Hmm.
The issue is, again, if you're allowing the population to remain unvaccinated, and every single person in the world who gets this, where the virus reproduces, there's always a chance that at that point in time, a more virulent strain will appear, because it's during infection that these things occur. Unlike bacteria, viruses are immune objects until they infect somebody and cannot change their genetic makeup until they start reproducing. Whereas bacteria are doing this in the environment all the time because they're living creatures. And not only that, they share genetic resistance with one another, even if they're not even the same species of bacteria. So so this resistance can actually occur within the environment without infecting anybody. So I am, and I'm not contradicting anything he's saying about this, but the longer it takes to vaccinate the population as a whole, the more chance we have of getting a strain which is not 60% effective, but 30% effective. And then the evolutionary pressure of how these diseases work, suddenly in the area of the world where people were immune, they're not immune anymore, and we're going to see recrudescence of illness. So it's this failure. And I agree. I'm thinking, a friend of mine called me today and said, I've got a way of jumping the queue. Should I be doing this? And I said, do you want to act in an ethical, responsible manner, or don't you? And he said, I want to act in an ethical, responsible manner. I said, then you know the answer to this. And I said, by the way, given that you live like a hermit, you're not going to get infected. And if you wait until the fall, you may actually get a better vaccine. And
Yeah.
one of the things that's happening because of the technology is that Moderna and Pfizer are going to be retooling their vaccine. It's going to take some time for them to do it, but the people at the end of the year may actually get a better product than the one we're all getting now. So there may be a positive aspect of this. I'll
Yeah.
shut up. I'm
No, thank
speaking
you.
for Greg, but
Thank you. for
Another, looking at public health, how did we eradicate smallpox?
Okay, so we had some nice advantage with smallpox. Smallpox only infects human beings, so we didn't have any reservoirs in nature. Like we think the COVID probably came from bats. There's a group of WHO scientists in China right now tracking it down. It took a year to get into China. So that was one thing. The other thing is when it's also relatively stable. It doesn't mutate quite as much. And we forced vaccination on people. It was the 1960s. Bioethics didn't exist as an enterprise yet. And so we literally, anybody who refused the vaccine, we literally held them down and injected them anyway. It was a force, well, we've variolated them. So it was everywhere in the world. You could not refuse. That's how we managed to do it. We violated human rights.
But it worked.
It did work. I'm November 69. I'm one of the last people in the world who got a smallpox vaccine. Yep.
Interesting.
Shoma?
That if the vast population had been vaccinated, there would be less strains and variants coming out of it. So in that case, are there medical ethicists on boards of pharmaceutical companies? I'm just
There
asking.
are.
So then they are well aware of that.
On boards, so they have ethics boards. They have separate ethics boards. Yes.
Separate is dubious in the sense, if you know this is and you're building cost into it, the fact that you decide not to give these medicines, it's almost criminal if you look at it that way. If you know one is going to die in, say, Zaire, which you said is one of the 25 vaccines, ethically on a bigger platform, because you are global companies, perhaps the question of responsibility or obligations, those questions don't come up. Isn't that
They don't come up. So I've worked with pharmaceutical companies before. And I worked with the innovations group of a Japanese company, and they were very thoughtful. They did care about the ethics. They actually cared about helping people.
They have a German medical system, right, in Japan?
Japan is an interesting hybrid system. It is more like the German system, yes. Well, no, it's actually the flip of the German system. So they have it's kind of unique, but it's a pretty cool system. It works. Everybody's covered. Everybody can have healthcare. There's difference in systems of whether it's private or public insurance, and then private or public hospitals and doctors. And so there's different variations of those two variables. I don't remember which one Japan does.
I would like to ask you, I mean, I'm kind of interested in what's happening in Chicago regarding the CTU and their administration, and where do we stand ethically on making teachers go into the classroom when the health issue to me is the predominant one? Where do we stand? How would you deal with that?
So it's funny. I was just responding late last night, answering some questions to a journalist about this. So we are, when it comes to like public schools, in this case, we're just talking K through 8 here in Chicago. It's really a balancing of harms. So there is a harm with students not being in school, right? One of the weird harms is we've got a lot of teenagers doing carjackings. Apparently there's a thing about taking videos of you doing carjackings on social media. So that is a challenge. There are teenage suicide has upticked because they're feeling isolated and alone without having their social networks. there's a lot of concern about the social and intellectual development of kids. So those are all harms. Children can get the infection. We know this. Their death rate is extremely low. But their teachers, some of whom are close to 65, the custodial staff, the cafeteria staff, the bus drivers, like, you're putting the adults at risk for doing all this. So the decisions that are being made is, where do you want your harm? So some schools, the CTU is saying health harm to the faculty and staff is the most important thing. And to bring it home, how's a kindergarten going to feel if grandma dies from COVID because they brought it home? So that's the CTU stance. The CPS stance, Chicago Public School stance, is the harm to the kids outweighs the potential health harm, because it's only a 1.7% death rate, and we don't really have that many people who fall into the high risk category. So it's probably worth it. There's no right answer here. There's no good answer. These are, what's the best bad answer? That's what we're dealing with. So there are schools in this country that have opened successfully, school systems. They tend to be in small rural towns where there is low community spread. They're in large cities with large community spread where you can't control where people are going outside of the school. It doesn't work. You're going to have spread. In the first week of CPS opening, they had to close several of the schools because there were outbreaks in them. Several of the pods got sent home in many different places. So no, you cannot open a school without spread, period. How much spread are we willing to have? That's the question. So my university, DePaul University, we've been closed since mid-March. We are not really opening until the fall. We're hoping to open in the fall. That's our plan. Because by the city guideline, anybody who wants a vaccine will be able to get it. But but we also realize we're probably gonna have to change our entire plan come July.
It's been interesting. My grandchildren's school, which is a Jewish day school, and very controlled and very clean, and they are learning in pods.
Mm-hmm.
And after vacations, because they don't trust the parents that much, because not all the parents are behaving correctly, they take a break from the school so that there is it's a 10-day break. So if there's going to be infection, they'll see it in the parents,
Mm-hmm.
but the kids aren't bringing it into school and infecting everybody else. So my Chicago grandchildren have been very lucky. For the most part, they've been in school. My New Jersey kids, it's sporadic. But whoa.
Are your New Jersey kids in private school or public school?
Public.
You see, I mean, because the private schools have, a lot of them have been open all the way through. One of my classmates is at Brearley in New York, a pretty large, I think there's something like 1,200 students. It's a large private school, and her job is to keep it COVID free. And how they do it. And they're doing okay, but they have the money to invest in ventilation systems, and the power to say, you don't wear a mask, you're out of here, which is harder to do, but it happens. I mean, that's a big school.
But it's been fascinating watching my Chicago kids' reaction to people who had been close friends, who they look at differently now because they didn't respect any of the restrictions. They went off to Cobo as a group. And friendships, they have to be cordial because they're going to be together for a bunch of years. But the depths of the friendships no longer exist.
Wow.
I just want to add something to what the Chicago public school system is facing. We have a lot of friends who have kids in private schools, as well as public, and there's a very important differential here. Again, I think it's privilege comes into play. The private schools, the classes are small,
Mm-hmm.
and they can make little groups of kids. Like our neighbor stays with 6 children all day.
Right.
There's a bubble created, and the people they come in contact with are controlled in terms of their external contacts. So they know exactly what they're dealing with day by day, minute by minute almost. The ones who go to public school, and they also have the space in their school to spread out. It's a
Correct. That's my kid's situation.
Yeah.
the schools are beautiful facilities. Public school, my goodness, when's the last time you saw a new Chicago public school going up? They're old
Never.
buildings, they are large classes.
Sure.
And no matter how much help you have, you can't spread them out. You can't keep them, you can't physically distance. There just isn't the space. So, I mean, there's really the issue for Chicago Public School and the CTU, I think goes way beyond the issues that we're talking about. And I think they're really the issues that are crucial to improving our education in general. I think the private schools just have so many advantages over the public school kids at this point that I don't have a lot of hope for them.
The other question for the ethicist is, okay, so now you make a decision to really use your vaccine to give to the teachers
Yeah,
so that you
that's
can
another
open up
issue,
the
yeah.
schools and have normal classes, or at least reduce the possibility of serious illness. Because as you know, even the partially effective vaccine, it's meant to keep you from dying, okay? And it does a good job at that. So the question then comes up, what about teachers who are going to refuse vaccination? Are they to be fired and say, sorry, you can't work here anymore?
Yep.
Because and you're the reasons you're not showing up and the reason you're striking is off the table. So that may come to that as well, if they can get the vaccine supply up and actually say, okay, Monday through Friday, show up, you're getting your first vaccination, and then a month later, you'll get your second, and 2 weeks or 3 weeks after that, school's opening, open for business, show up. If you don't, you're fired.
So you can't do that. Legally can't do that. So first of all, these are only emergency use authorizations. So you can't require an emergency use vaccine. Not allowed to do, especially in a public system, public institution, cannot do it. There would be lawsuits and they would win. Secondly, so no, that's not going to happen.
So
They may make it available, but they can't. So even in a hospital, if you have, say, which is like a place where everybody should be getting it, and they're not, what all the hospital can do is assign them to duties that don't have patient contact. That's all they can do.
So actually, I knew the answer to that ahead of time.
It's a trick question.
Well, in a way it is, and in a way it isn't. I knew the answer because you and I discussed this in previously. Then the question comes up for the CPS. Short of the pandemic disappearing and having a natural death 2 years from now, or whenever it's going to happen, if it ever happens, when are you going back to work? Because really, when it comes down to it, you cannot eliminate their risks
Completely.
Right. So, I mean, it's a good question. And, I think that people are battling heads over what they think is important right now and how the decision be made, that they're not getting to the point of making a decision. So first, we got to kind of get on the same grounds of how we're making decisions. I mean, the reason that I heard CPS give for wanting to get back in person was that the children are being harmed and that harm is falling disproportionately on populations of color.
Yeah.
However, when you look at who has chosen to put their children back in school, it's mostly people, it's mostly white and Caucasian populations. So it's not achieving the aim. And if a program is not achieving the aim, you've got to rethink your
That's the
programming.
point.
So
Oh, my goodness.
There are no
nothing is
answers.
easy. There are no answers. There are bad options,
Yeah.
and we try to pick the least bad option. That's kind of where we're at.
Wow.
And we've got 50 states choosing their own way of going.
50 states plus territories, plus the federal government. So the VA does something separately within all these states, plus the major cities are separate in their decision making from the states.
But
But they
then you
aren't.
have the CDC coming out and they're saying that it's safe to have person-to-person instruction if you follow their guidelines.
But they haven't given those guidelines yet.
But they have.
They gave guidelines way back a year ago, but they weren't evidence-based guidelines. They were politically based guidelines.
Oh, I thought they redid them. Are you
The new ones haven't come out yet. They've only been given their marching orders about a week ago. It's going to
Yeah.
take a few months.
It seems to me that there was a case that I've read that companies can require that you be vaccinated.
It is
Their employees
And that may
potential.
be the difference between private and public. And
So,
certainly
yeah.
it's a little bit different, but there certainly have been cases where you certainly had to have a TB test for various things like being a teacher. And I don't know what vaccines, but it seems that there is, I mean, you'll know more about this, but there's some precedent for vaccines being required.
So there is public health law. There's a Supreme Court case from the 1880s that said you could, one in Massachusetts and one in New York State, that said you could community can require vaccines. Now, because we're a society that has a public system and a private system, there are different rules for each. So in a public system, it is much harder to require a vaccine, much higher. And it's almost impossible to fire somebody for refusing to take the vaccine because yes, we have Supreme Court laws Supreme Court rulings that say, yes, you can force people to take vaccines. We also have Supreme Court rulings that say you can't force people to undergo medical procedures without their permission. So the other piece of this in the private enterprise, the private world, private schools where I teach, you can force people to do things because if they refuse, you actually don't have the same constitutional rights with a private employer as you do with a public employer. It's very different. I only have a right to free speech because my university gives me a right of free speech because the Constitution stops at the doors of campus.
Right.
So I think the test will become when there is full FDA approval and there will be some company that will say, yes, to work in this company, you must have been vaccinated. And there will be some people who refuse and they will sue. And there will be a court case that will go as far as it goes. It might be a state Supreme Court, it might be the US Supreme Court. And that is when we will have the legal answer to this question, but not before then, because we have conflicting precedences. So we need a good test case. And that's how a lot of these things end up getting answered.
Wow.
And I know this because I've worked with our legal counsel at DePaul on answering this exact question.
Craig, this was incredible.
So
And,
interesting.
and with anything like this, it created more questions with the more knowledge we had.
Yep.
And I don't think a lot of us are going to sleep tonight, quite honestly.
Took me about a week before I slept once I figured out the vaccine thing. Yeah.
Yeah, I
God.
mean, so many questions. And it's the old thing about The more knowledge you have, the more questions you have, and they become more refined and smaller,
Mhm.
down to particle physics.
Yep.
Any questions?
Good grief.
I will put my email in the chat. Might take me a little while to get back to you, but I'm happy to answer any questions
Oh,
people may come up with. Or
fabulous.
want to chat.
Fabulous.
Thank you.
Fabulous.
Thank you for having me.
Craig.
Pleasure to meet you
Thank
all
you.
and see you here today.
Ciao.
Bye.
Stay safe. Wear your
Yeah.
You
masks.
too.
We wear masks and distance.
Wear 2 masks. Stay at
I
home.
know.
Distance.
I
Wash your
got
hands.
them now.
Good. Thank you.
Bye.
Bye.
Ciao.
Did I send it to you? I think it's gone. That's okay. Thank you.
Wow. This was a scary day, kids.
It's hopeful and it's scary, and theoretically the truth shall make you free.
That's very funny.
Okay.
Yeah.
Love you.
Ciao.